Now for something completely different. MS is a neurological disease. It affects the body, but the mind and the body cannot be dissociated. And there are many issues affecting mental health that occur in people with MS and influence the behavior and the course of the disease. Our next speaker is Dr. Jennifer Finkel, and Dr. Finkel is an assistant professor of psychiatry and neurology at Mount Sinai School of Medicine. And Dr. Finkel is relatively unique in the world, perhaps unique, entirely unique, in being a psychiatrist who has been specifically trained in MS. A few years ago, she spent a year with us as a fellow at the Corinne Goldsmith Dickinson Center after she completed her residency in psychiatry at NYU School of Medicine and Bellevue Hospital. Subsequent to that fellowship, she joined the faculty at Mount Sinai, where she's continued to work closely with the MS community. In 2005, she was part of the Goldman Consensus Group, a panel of MS experts studying or addressing the issue of depression in MS. And she now serves as the primary psychiatric MS consultant and geriatric consultant for Mount Sinai Hospital. She's dually boarded in both psychiatry and psychosomatic medicine, and is currently the clinical director of the Department of Behavioral Medicine and Consultation Psychiatry at Mount Sinai. Dr. Finkel is going to talk to us about MS and the mind.
Thank you, Dr. Miller. So today I'm going to be talking about MS and the mind. So why does it make sense that MS, which is a neurological disease that primarily affects the brain and spinal cord, could have psychiatric manifestations? Well, by looking at the slide, we can see that it lends itself to the age-old question and conflict between neurologists and psychiatrists regarding the duality of the brain versus the mind. Whereas neurologists' primary area of focus is the brain, psychiatrists have always focused on what's called the mind. But the question is, are the two things really the same organ? Do they do the same thing? And recent evidence in psychiatry suggests a much stronger biological basis of psychiatric symptoms than was previously thought. So whereas before the invention of psychiatric medications, it was thought that psychiatric symptoms resulted from the product of environment, or how one was raised, or what kind of mother you had. Although that's still probably important, it's also been shown that it's probably equally important biological correlates in terms of mood pathways that are localized in the brain. So therefore, it should make sense that MS, a disease that can be characterized by inflammatory lesions in the brain, can also cause psychiatric symptoms because the mood pathways that are important for causing psychiatric symptoms are also localized in the brain. So are the mind and the brain the same? Psychiatry and study of the mind has traditionally taken into account the whole person and more abstract theories of thought, mood, and behavior. Neurology is rooted in basic science, medicine, and physiology. It clearly focuses on the brain and its function, the hows and the whys, normal versus pathological. And today, there's a strong tendency to wipe this distinction away and rejoin the disciplines. And again, that's partly because that psychiatric disturbances research has shown that they definitely have biological correlates, and that there's organic, meaning medical, neurological causes behind psychiatric symptoms. So let's talk a little bit more about the mind. What is this entity that psychiatrists refer to so often? Different definitions exist. One is the human consciousness that originates in the organ of the brain and is manifested especially in thought, perception, emotion, will, memory, and imagination. It's the collective conscious and unconscious processes that direct and influence mental and physical behavior. It's the faculty of thinking, reasoning, and applying knowledge, the conscious mental events and capabilities of an organism, the organized conscious and unconscious adaptive mental activity of an organism. So let's just go a little bit further, and then I'll give a very simple definition at the end. The mind is the aspect of intellect and consciousness, experienced as combinations of thought, perception, memory, emotion, will, and imagination, including all unconscious cognitive processes. So when I talk about unconscious cognitive processes, an example of an unconscious cognitive process is things that we do that we're not consciously aware of, like defense mechanisms. So you might have heard of repressed memories. That's an example of an unconscious process. The term of the mind is often used to refer by implication to the thought processes of reason. So in its simplest definition, the mind is what the brain does. So influence of the mind and brain on each other. We know that the brain can create mind. Without brain, there is no mind. So that makes sense. But I also want to talk about something a little bit more progressive, which is how the mind can create brain. But as to the former idea, the brain creating mind, for example, in terms of the psychiatric disturbance of depression, it's thought that certain neurotransmitter abnormalities localized in the brain, like deficiencies of a neurotransmitter called serotonin, is probably important in the pathogenesis of depression. So a lot of the medications used to treat depression, the psychopharmacological medications, actually target this particular neurotransmitter, serotonin, and increase levels, and thereby hopefully effectively decrease depressive symptoms. So that would be an example of the brain causing mind, meaning the brain causing psychiatric symptoms. So how does the mind cause brain? This is a little bit more of an abstract concept. So back in the day, before there was any psychiatric medication, how were psychiatric disturbances treated? Well, some of you probably heard of Freud, and the mainstay of psychiatric treatment was talk therapy. So it's now, and talk therapy is still used to this day, and there are various types, one of which I'll talk about later. So it's now thought that talk therapy works also via a biological process that just we don't really exactly know yet, meaning that talk therapy very likely causes biological changes in the brain and physiological changes in the brain, but we just can't really identify those changes easily with studies. So it's not that talk therapy works through some mysterious process. It actually causes biochemical, physiological changes in the brain, thereby leading to reduction of psychiatric symptoms. So why should we be talking about emotional symptoms and MS? First of all, it's exceedingly common. 2/3 of patients with MS will develop some emotional disturbance over the course of their illness. And that's a lot. It is misunderstood. It's my opinion that the psychiatric disturbances of MS, although they certainly can be reactive to being diagnosed with a potentially disabling and progressive illness, that the disease itself is probably more responsible for psychiatric symptoms than any kind of reactive depression. It could also impact the disease. Psychiatric symptoms in MS have been known to increase one's disability and one's experience of one's neurological symptoms. It's also been shown that certain psychiatric disturbances can negatively impact the disease by affecting a patient's adherence with the disease, thereby potentially altering the course. It can affect self-esteem. It can affect the family unit. MS caregivers have been shown to be 4 times as likely as other caregivers to experience stress and anxiety. It represents a controlled aspect of the disease, in a disease that's often thought of as extremely unpredictable. And most importantly, it's treatable. So what are the current thought? What are the most common emotional symptoms seen in MS? And there are several, but today we only have time to talk about the most important ones, and the most important ones are anxiety and depression. The prevalence of some kind of anxiety disorder within the MS community probably is about 30 to 35%, and depressive disorders have a lifetime prevalence in the MS community of 50%. So what does that mean? That means that 1 in 2 patients with MS will develop some kind of significant depressive symptoms over the course of their illness. So what is anxiety? How do we define it? We know it when we feel it. It's a painful and overwhelming sense of apprehension and fear, often marked by physiological signs such as sweating, tension, increased pulse, by doubt concerning the reality and nature of the threat, over an impending or anticipated ill, and by self-doubt about one's capacity to cope with it. And I always think it's best to try to understand psychiatric symptoms and psychiatric disorders with clinical cases. So let's talk about the case of Miss M, clinical vignette number 1. Miss M is a 24-year-old female teacher who has been having vague neurological symptoms for the past 10 years. She's been to multiple physicians, all with inconclusive findings. She presents with a severe attack of right optic neuritis, eye findings. Within 2 weeks, she's diagnosed as having relapse-remitting multiple sclerosis. Over the next 3 months, she researches the disease, the different medication, and checks her insurance status. She also notes increased tension, difficulty sleeping, and overall she feels more edgy. She's noticed that she's been late to work on at least one occasion and has missed one important social function because she just didn't feel up to it. So what are some key questions to ask about this case, or anybody who's experiencing psychological symptoms? One is, how long has the symptom actually been lasting? All psychiatric disorders have certain time constraints on them, and some disorders could be diagnosed in just a couple of days, and some actually require a couple of weeks or even years of persisting symptoms to reach that diagnosis. For example, depression, in order to meet a clinical major depressive episode, a patient needs to be experiencing the depressive symptoms for at least 2 weeks. So having 1 day or 2 days, a really bad day here and there, will not comprise an actual psychiatric syndrome. So another question one needs to ask oneself is, what is the level of distress? On a scale of 1 to 10, where is the intensity of the distress associated with the psychiatric disturbance? And lastly, has the emotional issue caused impairment in social or occupational functioning? So the case of Miss M is most accurately diagnosed as an adjustment disorder with anxious mood. It's a reactive anxiety. It's the development of emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the stressor that causes marked distress or impairment in social or occupational functioning. Once the stressor is removed, the symptoms usually do not last for more than 6 months. So you might be looking at this and thinking, well, I had that. Anybody would have that. And I agree with you. Anybody would have that who's diagnosed with MS. The first time, certainly, I would say a vast majority of patients would suffer this kind of syndrome. So I think people sometimes get wrapped up in psychiatric terms and they say, oh, don't pathologize me. It's just used to describe something. An adjustment disorder with anxious mood should be expected in MS, especially at the time of diagnosis. And it also does not necessarily need to be treated with medication or anything like that. So why is anxiety common in MS? It's most likely that anxiety is reactive, unlike depression, which might actually be caused by the disease itself. The nature of MS requires frequent readaptation of coping mechanisms in order to handle the unpredictable nature of the disease, and this can lead to a sense of lack of control. It's been shown that when comparing MS patients with other chronic, even more severe medical diseases, that MS patients have more anxiety, even when compared with patients who have diagnoses that have a worse prognosis. And why is this? It's thought, again, that human beings are not exactly wired psychologically to deal with the ambiguity inherent in certain types of the MS disease and the relapse-remitting type. So what's the characteristics of anxiety in MS? It's more common in women. It's more associated with low to moderate disability, which might be surprising. But again, the relapse-remitting type of the disease usually is associated with the most psychiatric symptoms as compared with the more severe types. So again, that really probably reflects the unpredictable nature of the relapse-remitting type. It might be counterintuitive. One might think if somebody has more severe neurological impairments, they're going to be more anxious and depressed. But the data actually suggests the contrary. Anxiety in MS is associated with a greater experience of one's physical problems. So if you have a lot of anxiety and you have a neurological symptom, and you would experience that neurological symptom at an intensity of a 5, having an additional anxiety component, you might feel that neurological symptom at an intensity level of a 7 or an 8. It's heightened by fatigue and pain. And anxiety can ebb and flow depending on the disease course. So when can we expect to be anxious? At the time of diagnosis, during periods of exacerbations, and during times of progressive disability. So again, these are things that are to be expected and not to be pathologized. People are human beings, and this is within the normal range of psychological process. Now let's talk about Mrs. H, another clinical vignette. Mrs. H has been diagnosed with MS for the past 20 years. Over the past 2 years, she has diminished ability for walking and now uses a walking-assisted device. She has difficulty getting from place to place. Her husband notices that she never seems to want to go out anymore. Whereas they used to go out several times a week, she now prefers staying at home. She hasn't spoken to close friends in weeks and prefers solitary activities. She seems to shun visitors and avoids public places. Mrs. H can most accurately be diagnosed with the psychiatric disorder of social phobia. Social phobia is an anxiety disorder characterized by overwhelming anxiety and excessive self-consciousness in everyday social situations with intense fear of becoming humiliated in social situations, specifically of embarrassing oneself in front of other people. Social phobia can be limited to only one type of situation, such as fear of speaking in certain situations, which is called performance anxiety, or eating or drinking in front of others, or in its most severe form, may be so broad that a person experiences symptoms almost any time they're around other people. So I have certain opinions about social phobia in MS. It's actually been estimated to occur at a prevalence of about 7.8%, but I've actually seen this, I think, at higher frequencies in the MS community. And it usually involves 3 domains. Again, this is my own clinical experience. And the 3 domains that are usually involved are disability and walking-assisted devices. Patients with MS are usually diagnosed in their pretty young years, from ages 20 to 50. So I get a lot of patients who sometimes have a visible neurological impairment, and they're very concerned what other people will think of this visible neurological impairment. And this usually exacerbates with the need for a walking-assisted device. I've had some patients tell me, you know, I'm really young and I'm gonna go out and I have this neurological problem. What will people think that I did to have this kind of problem? So there's a lot of shame about it. Then there's issues of continence. Some patients with MS struggle with issues of bladder or bowel incontinence. Some patients need strict bowel regimens, and some patients need to self-catheterize. And sometimes patients have had accidents in public places. This is particularly traumatizing for patients and can lead to avoidant behavior. But it's important to encourage patients to find ways that they feel control of this situation, whether it's more frequent self-cath or bowel regimens that work, or seeing a urologist if necessary. And then there are the sexual issues of MS. Several patients with MS will experience some kind of sexual dysfunction. It could be decreased libido or erectile dysfunction. This can lead to performance anxiety, especially in sexual situations, which could not only lead to avoidance of the sexual situation, but also can impede one's ability to have an intimate relationship with somebody else. Another clinical vignette. Mr. N. Mr. N is a 34-year-old ex-college football player who has been diagnosed with MS for 4 years. He has always been athletic and exercised on a nearly daily basis prior to his diagnosis. Despite being relatively symptom-free for the past 2 years, he cannot help but worry constantly about his MS on a nearly daily basis. Despite education to the contrary, he believes exercise will worsen his MS, and so he rarely does. He worries daily about needing a walking-assisted device. The most accurate diagnosis for this patient would be something called generalized anxiety disorder. So you could see that this kind of anxiety in this Mr. H, in this clinical vignette, really permeates his everyday life. It's not a situational thing that is transient, it's every day. So what is generalized anxiety disorder? It is an anxiety disorder that is characterized by at least 6 months, notice the time constraint, of excessive, uncontrollable, and often irrational worry about everyday things that is disproportionate to the actual source of worry. This excessive worry often interferes with daily functioning, as individuals suffering from GAD typically anticipate disaster and are overly concerned about everyday matters such as health issues, money, death, family problems, friend problems, relationship problems, or work difficulties. They often exhibit a variety of physical symptoms, including fatigue, fidgeting, headaches, nausea, numbness in hands and feet, and muscle tension. And the thing I hear about the most with my patients is symptom-free patients who worry about progressive disability. And that's a very hard problem to manipulate because there is a need to prepare for that potential, but there's also the need to live in the here and now and not to spend all of your time worrying about something that may or may not happen. So the most common anxiety disorders seen in MS, the most common is most likely adjustment disorder with anxious mood, which probably everybody has at some point in their illness. The next most common is generalized anxiety disorder, which comprises about 20% of the MS population. Then there's panic disorder, which is intense, overwhelming anxiety, which develops over seconds to minutes and is characterized by fear of going crazy, fear of dying, fear that there won't be able to be escape from a certain kind of place, and it's accompanied by physiological symptoms like nausea, GI symptoms, tremors, hand numbness, heart palpitations. And obsessive-compulsive disorder is also more common in MS, occurring at a prevalence about 8%. Obsessive-compulsive disorder is the development of intrusive thoughts, which are the obsessions that lead to compensatory behaviors aimed at minimizing those obsessive thoughts, and those are the compulsions. So you might be familiar with the OCD patient who frequently washes their hands. The obsession in that case would be contamination, and the compulsion, the compensatory behavior, is hand washing aimed at minimizing the anxiety that's associated with the fear of contamination. So why should we treat anxiety? This is not, I don't know how much you can really see in this slide, but a lot of people think about anxiety and depression as pretty much on a cycle, that the two often travel together. A lot of times patients with depression have comorbid anxiety and vice versa. And most of the psychopharmacological agents used to treat anxiety can also be used to treat depression. So what is depression? Depression has different meanings to different people. It can be an isolated, sad mood, or increased irritability, worry, discouragement, apathy, which again would be an adjustment disorder with depressed mood, a reactive depression, also extremely common in MS and not pathological, or it can comprise an actual syndrome of major depression, which is accompanied by other symptoms. So let's talk about Mr. P. Mr. P is a 35-year-old male executive diagnosed with relapse-remitting MS 2 years ago. When he arrives for his usual appointment, the doctor finds Mr. M tearful and crying very easily. He also seems hopeless, irritable, and more uncooperative with the neurological exam. Mr. P admits that he's missed 4 days of work within the past month, which he attributes to fatigue and insomnia. His partner informs the doctor that for the past 2 months, Mr. P rarely seems to enjoy things that he used to, and he has said on at least one occasion, "What is life worth living for?" Major depressive disorder, and that would comprise the syndrome that Mr. P seems to be suffering from. It's the presence of at least one major depressive episode, which is defined by the following. It's a depressed mood or markedly diminished ability for pleasurable activities for at least 2 weeks. So again, this needs to go on for at least 2 weeks, accompanied by at least 4 of the following symptoms. Sleep disturbances, usually sleep is decreased but can be increased. Change in interest, decreased, guilty feelings or diminished self-esteem, low energy, concentration is decreased, change in appetite, usually it's decreased but can be increased in atypical types, psychomotor retardation or agitation, which refers to one's actual movements slowing down or kind of speeding up in an agitated way, and suicidal thoughts, which is obviously the most serious symptom of depression, thoughts of wanting to end one's life. So why is it important to talk about depression and MS? Well, as I mentioned earlier, there's greater than a 50% lifetime risk for depression in the MS community, which is actually 3 times that of the general population. In the general population, the actual prevalence is 10 to 15%. And it's been thought that there's even higher rates for lower-level depressive syndromes. There's also a greater prevalence of depression in MS, even when compared with other chronic medical and neurological illnesses. So again, they've done studies comparing the depression rates in MS patients as compared with patients with other neurological diseases like Lou Gehrig's disease and Parkinson's and even spinal cord injury. And MS patients, which even sometimes have a much more favorable prognosis than patients with the other disorders, seem to have higher rates of depression. What are the characteristics of depression in MS? It's greater in females, and that you've noticed when I mentioned what the symptoms were, that some symptoms between MS overlap. Low energy, which is seen in more than 80% of MS patients, could actually occur in depression as well. Cognitive issues and psychomotor retardation are also part of a major depressive episode. Depression in MS is often prevalent when fatigue is a prominent symptom. It's more common when there is a family history of it, and it may be associated with a young age, a time of diagnosis, decreased social support, isolation, and a type of coping strategy called emotion-focused coping, which hopefully I'll get to. So again, why is there such a strong association between MS and depression? We already talked about the mood pathways being localized in the brain, and that in MS, lesions can occur along these pathways that regulate mood and can therefore lead to psychiatric disturbances. But there is also a new, more progressive idea that inflammation is actually a key component of depression, that inflammation causes and is caused by depression. We know that inflammation is a key variable within MS, so it's thought that MS and depression may occur at such high rates together because of this common final pathway of inflammation. Are there other reasons MS patients might have depression? There are psychosocial causes that are not biologically mediated. MS can affect one's representation of the self. A lot of people view themselves in terms of their appearance and what they're able to do and what their bodies are able to do, the whole mind-body connection. If one's body is not able to do what it once previously could, one usually needs to alter one's representation of oneself. It can affect one's role in the family and one's identity. There's a need for adjusting to possible disability. There are possible effects on employment. There could be sexual effects. There could be effects on relationships with friends and significant others. So why is it important to treat depression in MS? First, depression affects one's functional status. Patients with depression who also have MS feel their disabilities as more intensely. They have increased disability and can often experience cognitive symptoms, which is also prevalent in certain types of MS patients. They can experience those cognitive problems as more distressing. MS patients with depression tend to have more disrupted social support. It can affect neuropsychiatric domains. It's also been shown, and I'll talk a little bit about this soon, that treating depression can actually improve fatigue. And there's a couple of reasons why that is, but also the fatigue that somebody might be experiencing in MS, though MS certainly has a very high association with fatigue in and of its own right, the fatigue might actually be part of a depression. So it's important to flesh out what is causing the fatigue. Is it the MS, or is it a potential depressive component to the MS? Depression has also been shown to be an independent risk factor for decreased quality of life in MS, and is probably the most important risk factor for decreased quality of life. So one can therefore argue if we treat the depression, then we're going to increase the likelihood that a patient's going to have a better quality of life. Depression is not a self-limiting event. It can worsen if not treated. It has been theorized to precipitate episodes, which I'll talk about in a second. But again, if depression is accompanied by a pro-inflammatory state, there's theories that depression in and of itself, by causing this pro-inflammatory state, might actually have something to do with the precipitation of episodes. So if we could decrease depression and decrease inflammation, theoretically, we might actually be able to decrease exacerbations. Depression is often not detected or treated. It's often not recognized, and more than half of patients with MS, and when it is found, it is often not adequately treated. And importantly, having depression could decrease adherence to one's treatment regimen. It's been shown that patients with any chronic medical disease have decreased adherence over time to treatment regimens. The treatment regimens in MS are often very complicated, so depression is an additional component that might likely decrease a patient's adherence, so thereby potentially altering the course of the disease as well. Why else? Depressive symptoms like loss of sleep, poor concentration, mean we cope less well and things can go wrong. This leads to still greater levels of depression, despair, and negativity, with still worse physical symptoms, which leaves us less able to cope and so on. So it causes a cycle of helplessness and feelings of worthlessness and inability to cope. And coping in MS is one of the most important strengths a patient can have to actually deal with the disease. So treatment of depression and anxiety. Actually, today I'm not going to talk about pharmacotherapy, which is the medication management, which is the thing I think people are most afraid of and wary of. That is, you see a psychiatrist, the first thing they're going to do is say, take medication. So today we're going to talk about alternatives to medication. One is enhanced coping mechanisms, and the second one is talk therapy. And there are different modalities of talk therapy that can be employed. The one that I'm going to focus on today is cognitive behavioral therapy, although there are various types of talk therapy that can be used. There's supportive therapy, which is basically supporting a patient where they are, supporting their defense mechanisms, relaxation training, insight-oriented therapy, which is the kind of therapy you've probably seen on television about exploring unconscious conflicts, music therapy, exercise therapy, couples therapy, family therapy, group therapy, and phone therapy, which is often delivered within the MS community and is extremely helpful. So first, to coping strategies. What's a coping strategy? It's adjustment strategies people develop to deal with an adverse situation. It's crucial in MS, a disease that requires self-care management, frequent monitoring, and adaptive techniques. It represents an aspect of one's personality. So let's talk about the spectrum of coping. I like to think of the spectrum of coping as occurring on this line, where on the far left you have avoidance strategies, people who basically out of sight, out of mind, it doesn't exist. And on the far right you have obsessive people who think about the disease to the exclusion of everything else. And it's pretty clear that neither one of these coping strategies would be exceedingly helpful. So what we want to focus on is actually problem-focused coping. So first I'm going to talk about the unhelpful type of coping, which is emotional focused coping, which is a bit of a misnomer because it actually is not encouraging emotional outbursts at all. It actually is trying to hold the emotion in. It's a coping method aimed at diminishing the experience of negative emotional states by using avoidance, denial, wishful thinking, and creating positive interpretations of one's reality. It stems from the notion that one is helpless to actually alter one's reality, so avoidant techniques are used. This is important in terms of, is this something that would be smart to do in a disease like MS? Is one actually helpless? And the answer is no. There are treatment modalities that are available that have been shown to impact the disease. To assume that one is helpless against the disease is not only a helpless stance, but is really not a true stance to take either. And emotional focused coping, this avoidant, wishful thinking method, has been shown to be more associated with depression, stress, and possibly an increase in exacerbations. So what's problem-focused coping? It's what you think it is. It's turning an unsolvable problem into a problem that has solutions, and it utilizes cognitive, behavioral, and emotional techniques. Cognitive techniques involve reappraising one's situation. The behavioral technique is thinking about a possible solution to the problem at hand, and the emotion that we encourage during problem-focused coping is allowing the expression of distress and anger. So it's basically the exact opposite of emotional focused coping. It's a proactive, direct attempt to change stress, and it's based on the belief that one can have an impact on one's reality. Cognitive behavioral therapy. So the reason that I talk about this type of talk therapy today is because it's been studied really well. It was introduced in 1967 for the treatment of depression, and right now 91% of research is supportive of its efficacy in the treatment of depression. It's also been used in the primary care arena, not in just MS patients, but in patients with diabetes, COPD, and dialysis patients with high response rates, at least 50%. Also, what's interesting about cognitive behavioral therapy is that it's been shown to be equally efficacious to medication to treat mild to moderate depressions. So what is cognitive behavioral therapy? It's based on the idea that there's faulty information processing going on in one's mind, which leads to cognitive errors, skewed interpretation of experience, and these cognitive errors need to be corrected. So the goal is to target the faulty perceptions and use behavioral strategies to create a more realistic construct. It uses the integration of healthy problem-solving skills to gain a sense of control. So let's talk about an example of CBT and its application to depression. So it's thought in CBT circles that one of the most common cognitive themes seen in depression is the theme of failure. People arrive at the conclusion that they're failures, and most times this is not actually evidence-based in any way. But it's such a negative construct, it leads to a patient having a negative representation of the self, the world, and their future. So the therapist's goal is to target these themes, the theme of failure, and identify automatic thoughts that lead to them and use behavioral techniques to correct them. So for example, if you have a patient with depression who constantly is telling themselves, I'm a failure, I'm a loser, I'm terrible, the goal is to basically replace those ideas with more positive thoughts and challenge the patient, really what have you done that suggests that you're a failure? Think of something positive about yourself and stop the automatic thoughts. So what's the relationship between cognitive behavioral therapy and MS? In a 16-week study, cognitive behavioral therapy was shown to be equally efficacious as an antidepressant at treating depression, and both treatment groups demonstrated decreased levels of pro-inflammatory agents. So what are the challenges? Recognizing the symptoms and seeking out help. It's important as clinicians that we ask our patients how they're feeling emotionally. It's also important that as our patients, you can come to us and feel comfortable asking us to talk to you about some uncomfortable topics. Destigmatizing psychiatric treatment, expecting that there can be emotional issues as part of MS, the disease process itself, and locating resources. So what are the benefits of treatment? For example, depression and MS, as we talked about, is an independent risk factor for impaired quality of life. Treatment of depression appears to improve fatigue. Treatment can theoretically lead to fewer relapses by the pro-inflammatory hypothesis I suggested earlier. And by treating depression, we can improve adherence to disease-modifying therapy and hopefully alter the course of the disease. Thank you.
All right, thanks, Dr. Finkel. So those of you who came in early today saw a video of the Corinne Goldsmith Dickinson MS Center in operation. Multiple sclerosis is a very complicated disorder for many people, and no one healthcare provider or one particular discipline, as I think you've already sensed this morning, can really have all of the answers. We're very proud that the Dickinson Center was one of the first MS centers in the country to be certified by the National MS Society as a comprehensive clinical care center. And that's because we're able to provide care for many aspects of the disease with a variety of different professionals. So I thought that it might be helpful for those of you who don't know how a comprehensive care center functions to see a couple of examples of how we try to work together to address the problems that people have with MS. So I'd like to introduce three of my colleagues. Tova Epstein is a licensed clinical social worker who, along with her colleague Donna Siegel, provides full-time social work services at the center. In so doing, she assists patients and families adjusting to the stresses of chronic illness and related social service concerns. Tova received her degree from Hunter College School of Social Work with a focus on individual and family counsel. She's run a number of workshops and support groups for the National MS Society. She'll be joined by Dr. Tracy DeAngelis. Dr. DeAngelis is an attending physician at the Dickinson Center and an assistant professor of neurology in the Department of Neurology at Mount Sinai. She received the National MS Society Clinical Fellowship Award in 2007 and 2008. Previously, she graduated cum laude from Dartmouth College and got her medical degree from SUNY Upstate Medical University in Syracuse, and then trained in neurology at Mount Sinai. Dr. DeAngelis is currently involved in a number of clinical trials and has developed a particular interest in a disorder that's closely related to MS called neuromyelitis optica, as well as to progressive forms of MS. The third person in our group to discuss a case is Aliza Ben-Zacharia. I'm going to defer my detailed introduction of Aliza until later on because she's going to be giving a talk all by herself this afternoon, and so I'll introduce her fully later. But now Dr. Ben-Zacharia is an experienced nurse practitioner at the center. So Tova and Aliza and Tracy, wherever you are, I can't see you, but I hope you're here.
Thank you. So Aliza, Tova, and I are going to present the application of a comprehensive care model to the management of two patients with MS. Firstly, a newly diagnosed patient, and later this afternoon, the case of a patient with long-standing MS. So, what is comprehensive care, and what is its role in the care of patients with multiple sclerosis? MS is a complex neurological disease with an unpredictable course and potential progression of neurological disability. It can involve a wide spectrum of variable symptoms that affect many different neurological functions and greatly impact not only the patient, but their family, caregivers, and the community at large. Historically, prior to the mid-1990s, care for MS patients was mainly symptomatic, with episodic interventions for attacks. With the advent of disease-modifying therapies, this has since evolved to focus more on prevention of new attacks, symptom management, and improving quality of care. In order to address a wide range of symptoms, MS patients need involvement of a team of specialists from many different disciplines: clinicians, subspecialists, researchers, support staff, extending well beyond the scope of a single neurologist. This approach has been found to be the ideal and most effective, efficient means to deliver MS care. So here is our team, starting with the patient at the center, and followed by their on-site MS neurologist, nurse practitioner, and social worker, all of whom can coordinate specific treatment concerns with subspecialists in a number of areas. For example, psychiatry, urology, physical therapy, physiatry, neuro-ophthalmologists, primary care physicians, our clinical trials research team, as well as the resources of support staff and the National MS Society. So this team approach offers several advantages to the care of MS patients. Comprehensive care facilitates the coordination of very complex care issues. It fosters better communication and continuity of care. It enhances support for both the patient and the care team, and it enables checks and balances. Patients often find a specific member of the team that they're most comfortable with. They may have an easier time discussing details about their symptoms or treatments with this person, and not all patients find it easy to admit, for example, to their physicians if they're struggling with their medications or if they're even taking their medications. This important information sometimes is discussed instead with the nurse practitioner or the social worker and is brought to the attention of the team. And it helps us identify the best tolerable therapy for a patient and therefore optimize adherence to their medication. It also broadens the case perspective with everyone bringing something to the table. And importantly, it's a patient-centered model, and this offers empowerment to patients to take an active role in directing their care. So in summary, it helps us identify, address, and overcome obstacles to implementing care with the shared ultimate goal of better managing a patient's MS and improving their quality of life. So now let's look at how this model translates into clinical practice with a look at the diagnosis and treatment of a patient who is newly diagnosed with MS. A 26-year-old graduate student who's getting her master's degree in teaching is referred for a second opinion regarding diagnosis and treatment. She presented with numbness, tingling, and weakness in her legs and a band-like tightness around her waist. 6 months prior, she recalls an episode of 3 days of double vision that resolved completely and for which she did not seek medical attention at the time. Her medications include oral contraceptive pills and occasional ibuprofen. She is single, she lives with her school roommate, getting her master's degree in teaching, and she works 2 days a week as a kindergarten assistant. She's in a relationship with her boyfriend of 3 years, denies smoking, drinks an occasional glass of wine, and there is a family history of autoimmune disease. She is first seen by her primary doctor, who refers her for a neurological evaluation. On exam, we find diminished sensation in her legs, some mild weakness, brisk reflexes, and unsteadiness to her gait. Her laboratory studies are unremarkable, and her MRI of the brain demonstrates multiple white matter lesions that are typical for demyelinating disease, with several active lesions in her thoracic spine. She is treated with 5 days of IV steroids with some improvement, but relates that her current symptoms include residual burning, tingling in her toes, fatigue, and significant anxiety about her diagnosis and treatment. Her local neurologist refers her for a second opinion after recommending starting a disease-modifying therapy for MS. And so now she is referred to our center. This case illustrates several important issues that need to be addressed at an initial consultation. And covering all of these issues in one visit in an hour for an individual neurologist is very challenging. So there are several opportunities at each step for various members of our team. The aspects I would identify and then consider referral for team member support include diagnosis and the type of MS. In this patient with 2 episodes and typical MRIs, the diagnosis is fairly clear-cut. However, in certain atypical cases, we may need to present her exam or her MRIs and laboratory studies to other team members and specialists, for example, showing her films to neuroradiologists or having her see our neuro-ophthalmologist to determine if other possibilities should be considered. A considerable amount of time is also devoted to counseling patients regarding their diagnosis and treatment. And this is also another opportunity for members of our team to become involved, including our nurse practitioner, social worker, psychiatrist. Also, regarding which disease-modifying therapy to start, we need to review respective side effects of different medications, which therapy would best suit this patient's concerns about lifestyle changes or her medical background. Should disease-modifying therapy be started in a patient if she's considering getting pregnant soon? And addressing her individual concerns about symptoms regarding neuropathic pain, fatigue, and anxiety. With that, I'm going to turn the podium over to our nurse practitioner, Dr. Aliza Ben-Zacharia, and she's going to discuss symptom management and also getting started on disease-modifying therapy.
So getting started, let's say you decided upon one of the disease-modifying agents and what medication you're going to start, and at this point we're talking about injections. So always, it's really important to have realistic expectations. Many times, we always feel we start a new medications, we're going to get better. However, sometimes with the injection, it's not always you getting better. Sometimes you have even side effects that we need to deal with, but we wanted to hopefully maintain your stability. So it's always important to keep that in mind and to have realistic expectation, because otherwise you can get more disappointed. Definitely when we're starting a new medication, there is an adjustment period that both Tova and I will discuss together. It's all injection and the fear of injection and how you deal on a daily basis. Either you take a daily injection every other day or 3 times a week or once a week. It's really not important. You're dealing with an injection that you have to do for yourself, and most of our patients do the injections independently. Some have help from caregiver, which is definitely we encourage. It's always good to involve family in all the mode of care with the team, because it's almost the whole team together. It's much more comprehensive and better for patients. I do a lot of education when I train patients when starting a new medication, education about MS, education about the injection, education about how to deal with side effects and what to expect. Definitely sometimes these injection training are done at home, and this is just briefly about this. The only thing that I want to mention when people start medication, this patient is single, not married, of course, but she was interested in pregnancy, and anything can happen in New York City. We have a lot of people that are interested in pregnancy early on when they have a new diagnosis. So I always speak about when it's important to stop the medications, how to consider discontinuation of the DMA prior to conceiving and prior to dealing. We have a very small center at Mount Sinai, and we have few clinicians, and everyone has a different opinion about when to stop medication prior to pregnancy and to take medication during pregnancy and so on. But again, I think what really the importance is to have an individual discussion between you and your provider, either you're at Mount Sinai or elsewhere, always to be open and write your questions, because sometimes you come to the visit, you're so anxious, you forget most of them. The other part that we always deal as a nurse practitioner, physician, social worker, and many other team member is about symptoms management, how to tackle these symptoms that comes along. And sometimes they interact with each other. I'll speak more about symptoms management in the afternoon. But if you recall, this patient just talked about fatigue and some anxiety issues, and then she comes to me, and you would remember if she would mention sexual things to Dr. DeAngelis, but she had not mentioned it. And when she comes to me or to Tova, she might feel more comfortable. And that's the advantage of a team. You establish some kind of relationship with every team member. And if you feel more comfortable, you'll talk about bowel, you'll talk about bladder, you'll talk about sexual and intimacy issue. So I think that's really the one important thing when you have a comprehensive care team. And at this point, I'll transfer the podium to Tova to talk a little bit more about adjustment to different issues that come as you get along with the disease.
Hi, everyone. Oh, gosh. I knew I was going to have to do that. Okay. I think the first thing I'm going to mention before I start speaking is that I like to mention as the social worker that I sometimes feel like I have the hardest job, because when a patient comes into the center, they are prepared to talk about their physical problems and symptoms, but often it's pulling teeth to get the emotional stuff to come out. So we're here because we know that there are emotional pieces, and as you can see, it's all really interconnected. So please take advantage of the different members on your team, because you are a whole person, and there's lots of different things that come up. So just wanted to start like that. Okay. So I'm going to talk about the adjustment issues, but the first thing I want to do is look back at the case. And Dr. DeAngelis mentioned certain pieces of the case that might be the most important to the medical staff, But when I look at this case, I look at a young woman who's 26, and my first thought is, what is her relationship with her parents, with her siblings? Is she concerned about how to tell her parents how it's going to affect them? I think about, she's in a relationship for 3 years. I think about, what is this like for her dating somebody? Is she going to express feeling guilty and concerned about the future of her relationship? I think about her insurance situation. She's a graduate student. This is a flag to me because often graduate students don't have the greatest insurance, and sometimes I need to assist them in obtaining the medication. And ultimately, when I hear that she has an aunt with MS, I know that the doctor or nurse practitioner might look at it as a piece to the puzzle of diagnosis, but for me, I look at it from a social perspective. How was her aunt doing? Because I now know that this newly diagnosed patient is probably assuming that her future is going to be the image in her head of the person she knows with MS. And I can often predict, based on a person's reaction to diagnosis, who they, the person they know with MS, how are they doing? And so there's often a lot of education that needs to be done over and over again about the present state of MS and the future state of MS. So in adjusting to a new diagnosis, I think one of the most basic things that we can't take for granted is adjusting to being a patient, which many of you probably know is not an easy thing. With or without a chronic disease, you kind of feel a little bit vulnerable when you're in the office, and we're here to help remind you that we are a team and we're here to help, and that, we try to empower you. And again, while I can't take away the difficulty of having to go in and see your medical team on a regular basis, the hope is that over time you'll grow to like us as people. And maybe we can try to ease a little bit of that anxiety. Denial versus acceptance. Denial is a word that we throw around a lot, and I think before I really got into working with my patients, I used to think of denial as a terrible thing. And I will say there is certainly an extreme with denial, but there's also kind of a healthy level of denial, and I think this goes back to what Dr. Finkel was saying about the denial on one side and obsessive on the other side. Denial, when a patient is coming in to see me and they're taking a medication and they're coming in to see their medical team every 3 months, I would argue that even the patients who tell me they don't really believe they have MS are not really in denial, because you're doing what you need to do. So if you want to call it denial, we're okay with that, because what you're doing is helping yourself, and that's great. The unpredictability of MS, certainly I don't have to tell you guys that that is one of the most difficult things to deal with. And I can only say from my experience over the past 9 years that people really do adjust to that over time. And certainly in the beginning, the fear of the unpredictability is often more difficult than once you really get to understand that sometimes having the label of MS is partially just a label, and your life does continue. Adjusting to treatment. The thing I really hate the most is when a patient comes in and says, am I going to be on this for the rest of my life? There is really nothing in my life that I can look at in terms of for the rest of my life without feeling overwhelmed and miserable, even my very happy marriage. I think that it's just a very overwhelming way of thinking about anything. And the reality is we don't really expect anything to be lifelong. Many of you have probably seen over the years, there have been improvements and there have been changes, and we assume that that's going to continue happening. So it's always best to look at things day by day, week by week, and to think of it that way. Okay. I don't have so much time, so I'm going to try to touch upon all these things as briefly as I can. Disclosure. My guess is that everybody in the room has dealt with disclosure in a different way, whether you're family, whether you're a patient. This is a big concern for people, and the social workers at the center, a big part of what we do is really meet with people individually to talk about disclosure, because there's really no right or wrong answer, and we always need to take into account all of your specific issues and concerns. My main advice with disclosure, and certainly in this newly diagnosed patient, what I would advise is the most important thing is that you be okay with your diagnosis before you start to talk to other people. Because if you're not okay with it, it's going to come out in how you convey the diagnosis. And it might make the diagnosis seem, more severe than it actually is. Certainly when talking to children, that's my advice. Once you tell, you can't take it back, but you can always tell. So while I don't advocate keeping it to yourself, I think it's very helpful to have people you can talk to. I also don't think it's necessary when you come back from that first doctor's appointment and you're feeling so overwhelmed to run and tell everybody. Okay, regarding the social issues, I'm going to go on to dating now. Again, I am constantly listening to patients talk about their guilt. Whether it's someone who's dating, whether it's a child worrying about their parents, whether it's the parent worrying about the child, everybody feels an element of guilt around having a condition. And what I try to convey to patients is we all have some baggage. We all do. And, certainly in relationships, everybody brings something different to the table. And just a brief story I'd like to share about this. I had a patient who was newly married, was diagnosed with her MS, literally on the airplane on the way to their honeymoon, and was told over the phone, not by our team, mind you, but was told over the phone on the airplane, and came in for counseling, was talking to me, and felt so awful that she had brought, she got married under the pretense that she was, a healthy person and there were no major issues in the marriage. And she kept going on about that guilt. And 3 months later came in to see me and was telling me that her husband, who had a very successful company, the company declared bankruptcy and they were having terrible financial stress. And as I was sitting there listening to her talk about her guilt around her MS and how she's tired and how she has to work a full-time job now, it hit me that while I'm not saying the spouse should feel guilty at all about losing the job, but that's just the thing. Things happen in a marriage. And she was so preoccupied with her own guilt that she didn't even think that her husband, instead of feeling upset that, look what he got stuck with, of course he wasn't thinking that way. He was thinking, look what I've done. Look what I brought to the table. We got married and everything seemed great and we were thinking about having children and now I've gone bankrupt, and he was dealing with his own guilt. Okay, vocational issues. So as the other two speakers have spoken about, this is really, the side effects of medication is really a big area of overlap where we all talk together about what might be best for patient, whether it's taking a shot at a different time of day or sometimes even switching a medication because of side effects. Again, sometimes a patient will talk to me about not taking their medication all the time and they're afraid to tell their medical provider. I'm not really sure why no one feels intimidated by me. I don't know if I should be offended by that, but certainly there does seem to be more concern about telling their medical team than there is with me. And I always reassure patients that you work together and that doctors and nurse practitioners don't get angry with you. They work with you to make sure things work, and it's always important to let us know information. Just briefly, resources. There's a lot of resources out there. There's a lot of help. I would say one of the great things about being part of the MS community is that there is so much out there. The New York City, the MS Society is a wonderful resource. You have your team, the social workers. We refer people to groups. We educate. We have seminars. And sometimes we work with families in addition to the patients. Okay, I'm sorry. In conclusion, again, I hope that we've been able to convey to you how working with a team is so beneficial to your health. And again, if you have a good provider, you may feel that you're getting great care, and you very well might be. But I think sometimes you don't know what you're missing unless you have the opportunity to talk to different people on a team and address some issues that you may not even know are issues for you. So again, just in conclusion, we would like to stress to you the benefits of utilizing everybody on the team and speaking about all your concerns, and our hope is to really successfully manage your care in the best way possible so that you can see that you continue to enjoy your life in every way, and we help you with the bumps in the road when they come along. Thank you.
Well, Thanks, Tova, Aliza, and Tracy. We have about 10 to 15 minutes for questions before lunch. I'll ask Dr. Fabian and Dr. Finkel also to come up to the podium wherever you are. Thank you. And there are some people who will be circulating with microphones. So, but I have one announcement to make first. If someone named Michael Hauptman is in the room, they're not happy with you in the garage. You are blocking somebody else in, and you have walked off with your keys. So please retreat to the garage at once. We'll save you lunch. Here's the ticket. All right, we'll be happy to try to take some questions. Please try to keep them brief and concise and not addressed specifically to your own medical conditions. Here. I'll try to repeat your question if you... Well, here comes the mic behind you.
Dr. Miller, have you had direct contact with patients who have been treated for their CCSVI?
The question was whether I've had any direct contact with patients who've had CCSVI. I've had 2 patients who've undergone the procedure, one of whom experienced a lot of post-procedural pain, thought she had some subjective improvement in some of her symptoms, but was walking no better and perhaps worse. And the second patient had not experienced any improvement yet and had a clotting of her internal jugular vein after the procedure, which required 2 additional procedures, which failed to eliminate the clot in her vein, and she ended up being on blood thinners for 3 months. Gentlemen.
Hi. I've been sick for 52 years, and I'm a psychotherapist, and people frequently ask me what to do about people staring at them. I've got a very simple answer. You just stare back. It works wonderfully.
Thank you for the very helpful advice. There's a gentleman here in the center. Here comes the mic.
With respect to this CSSVI, when you made the rhetorical question about whether you thought it was malarkey or not, the inference I got is that you thought it was malarkey. But apart from that, it seems that the whole theoretical underpinning of CSVI completely overturns decades of theoretical research and ideas behind MS. I mean, it being basically autoimmune, T cells, and so forth. So CSVI appears to be beyond the pale of what we have been doing with MS for decades and spending billions of dollars of research. So how does that fit in with your analysis as its potential validity?
Well, first of all, you chose to emphasize the word malarkey in the title of my talk rather than miracle. I hope that most of you were convinced that although I might have a suspect that this is going to turn out not to be true, I've emphasized how important it is to get scientific answers to the question. It doesn't actually, even if this turns out to be true, and Professor Zamboni's hypotheses about the pathogenesis of the disease are correct, it doesn't totally eliminate the immunological aspects, because the implication is, Zamboni's implication is that the deposition of iron leads to an immunological attack. And even Professor Zamboni himself has emphasized that patients should not discontinue their immune modulatory therapy. Other questions?
Regarding the vitamin D deficiency, I'm over here.
I can't see you, but I got a waving hand, so
That's okay.
The light's shining in my eyes, so it's hard to see. Go ahead.
Okay. Regarding the vitamin D deficiency, are there any recommendations in terms of how much you should take, taking it orally versus injectable, And a two-part question as well. With African Americans or people of color, are there any specific research, since there are some very great differences?
I'll let Dr. Fabian respond to that.
You could have a level tested in your blood of vitamin D, and then based on that level, a doctor can give a recommendation. Without any level, it is safe, vitamin D. There's really no toxicity at even higher levels, but at low levels of 1,000 to 2,000 international units a day, it's very safe, so that's safe to take. But the level can guide you and your treatment staff to, with advice for the dose.
There is much more data about vitamin D deficiency as more of an increased chance to develop MS. So I always tell patients that, for example, have young kids or children at home to get them to see a pediatrician and check their vitamin D deficiency, because there is more association as to prevent MS. So again, it's an association, it's not harmful, but it's important, as Dr. Fabian mentioned, to check it and to check it over time, as your providers say, because you can become toxic if you take too much of vitamin D.
Maybe Tracy, you'd like to address the question about differences in African Americans.
So the issue regarding vitamin D deficiency, as Aliza mentioned, and also Michelle mentioned, is something that there has been some data to suggest maybe there's a relationship between a low vitamin D level and the risk of developing MS. And something that has interested people for many years regarding the longitudinal and latitudinal distribution of MS at a distance from the equator, with less MS historically found in equatorial regions. It's not clear whether or not a specific vitamin D level has an exact relationship to how at risk someone is for MS, but the darker skin a patient may have, the more difficult it is for them to absorb vitamin D from sunlight, and that may put them at risk for deficiency. Also, whether or not they're spending more time inside where they live, occupational concerns of not being outside and having adequate 15 minutes a day of sunlight exposure that may give you an adequate vitamin D level. So it can vary from patient to patient. There can be a relationship regarding skin color, and so as Dr. Fabian mentioned, it would be a good idea to assess your level and see what type of supplementation you need.
Hello?
Go ahead.
I
Hi.
read in the New York Times about the new drug, I think it's called Gilenta.
So I think we're going to defer that question because I'm sure that Dr. Lublin is going to be talking about that in his talk on therapies this afternoon.
I just want to thank you, the individual that did the presentation on depression. I found the information to be extremely helpful and a great understanding of that, especially as you pointed out, social phobias and performance anxiety regarding individuals with low and moderate disability. I think in particular, might want to even take it to the next step in terms of individuals with invisible symptoms. As a young professional, that's one of the things that I struggle with. And the audience may not see what I'm going through, but I know what I'm going through. And it could be quite interesting, when doing a presentation, when writing a report. So being able to talk about this in terms of through your PowerPoint, I just found it like a little light bulb. Hey, and just thank you.
Thank you, I appreciate Thank you, I appreciate that.
In the session,
On my
I was
right.
talking to a gentleman that was recommending medical marijuana. What is your opinion? Because that can have a physical and psychological effect.
So maybe I'll answer that. So first of all, medical marijuana is not legal in New York State. Second of all, let's just talk about marijuana. marijuana has been reported in a number of studies, as well as numerous anecdotal comments, to improve such subjective symptoms as pain and spasticity. And it's quite possible that it does that. It's also quite possible that it's a placebo effect in some cases. One of the difficulties in studying scientifically the effects of marijuana in MS or in any other medical condition, for that matter, is it's very difficult to blind the subjects. So, for instance, if you give some patients, one would like to know is, do the patients taking marijuana do better than the patients that are taking pretend marijuana? The problem is, you really know whether you're getting real marijuana or pretend marijuana. So, and I never inhaled, but
I don't think I can top that, but I have a story to tell you. I've seen a patient recently. He was debating if to tell me that he took marijuana or not. We had a little discussion. Of course, he didn't tell the physician, and we spoke about it in length, and then he mentioned that the day he took it, his balance was completely off, and he fell to the ground. Luckily, he didn't fracture anything, but just be careful.
Yeah, it is, of course, I mean, even when you're dealing with a subjective symptom like pain or stiffness, even if it's a placebo effect, if it works, it works, as long as it's safe. There are risks to the use of inhaled or smoked marijuana. It's significantly potentially toxic in the long run to the lungs, even more so than cigarette smoke. So,
Dr. Miller, you discussed smoking, but two things. First is smoking. You discussed smoking, but I'm interested in secondhand smoke and the effects of secondhand smoke for an MS patient who does not herself smoke, but is in a smoking household.
Yeah, I believe there has been one small report, I can't remember whether I saw it only as an abstract or not, suggesting even that the presence of secondhand smoke may convey an added risk for a negative prognosis in MS. There's no data about secondhand smoke and the risk of developing MS that I'm aware of.
Okay, my second issue is I'm a parent of a recently diagnosed MS patient who is, I think, with your team. And my daughter has turned me off to all information and says she's fine and she'll talk to me after Thanksgiving. And I'm just wondering if it's possible for a family member or a friend to be in touch with a team member just to be able to function properly herself. Not knowing is much worse than knowing, and it's a problem.
So I'm going to ask Tova to respond to that, but first I will say that one thing that we are always bound by are privacy rules and HIPAA regulations. So we are not allowed to talk even to a parent or a loved one, or even a spouse, about the specific case without the permission of that individual. But I'll ask Tova to respond to your question.
Sure. I think, first of all, I think it's great that you're here, and I think it's wonderful when we see the family members going out and educating themselves. So it looks like you are already educating yourself. I'm sure it does feel very unsettling, and when I spoke about my case, one of the things I had mentioned about this 26-year-old is that I did think about how she was going to worry about her parents in talking to them about it. Everybody seems to try to protect each other. We do sometimes meet with a family member without discussing specifics of the patient, because we understand that a big part of emotionally adjusting is just adjusting to the idea of the MS and the idea of, something is now happening with your child that you may not feel entirely in control of. So it certainly can be helpful to meet, one-on-one, or the MS Society has groups that may be appropriate, but certainly it is worth it for you to pursue that.
I know there are many others of you with questions, and we're going to have another session this afternoon with the panel. So now I'm going to stop so that we can have lunch. We've we fed your minds this morning, we're now going to feed your bodies. Outside the doors, you'll find box lunches that are set at various stations with a choice of 3 different sandwiches and a separate beverage. I'd appreciate it if you take your lunch as quickly as you can and then return to your seats in this room to eat. At 11:55, while you are still munching, Zoe Koplowitz is going to address us for about 25 minutes, and then there'll be a few minutes still before we resume. I know you're going to enjoy Ms. Koplowitz's talk, so scurry back with your sandwiches. Thank you. Nice job.